Our final speaker of the day is Ms. Tanisha Duncan, who leads the Tara Health Foundation Strategy and Investments in Birth Equity. Ms. Duncan, we welcome you to the table.
So much. Yes, thank you for your time. I'm so grateful to be here along with these other panelists, and a big thank you to the National Academies of Science, Engineering, and Medicine for the invitation to be a part of this conversation. Next slide, please. So I like to start with these grounding definitions, and I know we just had the team from National Birth Equity Collaborative here. So I like to start with their definition of birth equity: the assurance of conditions of optimal births for all people with a willingness to address racial, and social inequities in a sustained effort. Willingness being bolded and underlined there, and we'll talk about that in just another moment. And then birth justice, which happens when birthing people recognize their innate power to make the best health decisions for themselves and their families during all stages of the pregnancy, birth, and post-birth period. That power will have a transformational impact on their family and community. This from the Voices for Birth Justice, as derived from Black Women Birthing Justice, Southern Birth Justice Network, and Sister Song. I like to start with these grounding definitions because as we look at the purpose of this conversation in addressing research and funding needs to increase knowledge generation and improve outcomes, these definitions help us get to the root of for whom, with whom, and what outcomes are we talking about. People have shared over the last few days the need to address the root causes, expand the frame beyond just the event of pregnancy and birth, and understand that the increase in knowledge and elimination of disparities in pregnancy, birth, and general health outcomes requires a transformation across the entire ecosystem. We see from these definitions that what Black, Indigenous, and people of color are seeking, whether they be the pregnant person, the birth workers, community-based organizations, or people in large institutions who operate with this frame, goes well beyond the clinical metrics we've long used to drive the research and funding conversation, and in some places, it continues to still dominate. It's not to devalue the clinical outcomes, just if we're to really look at the issues, what's causing them, and adopt a frame and perspective in which surviving pregnancy is not the standard. People want more than that, they deserve more than that. Sovereignty and self-determination are the outcomes that we're seeking when we talk about pregnancy, birth, and health outcomes over the life course. Next slide, please. So to dive into this conversation, I want to first talk again about this willingness piece that was reflected on the previous slide. This gets to the core of the need in research and funding. And the title here says, as a funder, we start with these paradigm shifts, but really that's actually too narrow. It's really about any institution acknowledging the role of racism, sexism, misogyny, white supremacy culture, and how that creates challenges for people within those institutions trying to advance birth equity and justice. So we'll start with an institutional reframe. The power dynamics through dominant culture systems in these institutions create challenges in the work. We have to acknowledge the racism within these institutions where funding and research happens. It's not only the pregnancy and birth outcomes, this is the reality for the Black, Indigenous, health workers, researchers, scholars, clinicians, etc., who are trying to advance this work. I've seen firsthand how these power dynamics create barriers. The actual systems within these institutions are not designed to support this work, and that actually has to be addressed in order to shift the power and assets to the field. If the organizations that we're funding, the organizations leading in the research are changing the way that they're operating, we must also do the same, mirror that change. We created these systems, and we can and we must change them, but that willingness is the key. And then it's funding the paradigm shift. It's listening to our partners, which Monique talked about, auditing who, why, and how we've done the work, who we value as partners, what we value as expertise, and how we perpetuate inequitable systems of power by not making this space at the table And the space at the table right now is the dollars. We have to fund the people who are shifting us from just a frame of diversity, just clinical outcomes, and from this frame of death to the folks who are sharing what's working, what's addressing root causes, what's actually building power. And that means listening to, amplifying new leaders beyond any sort of tokenism, but really creating inclusive spaces for people to be at the table. And the third is this acknowledgement and understanding of economic justice, the role that under-resourcing plays not only for access for pregnant people, but also for the folks who are delivering care to them. In this way, we are really exploring and adopting giving without restriction, leading with trust, building power in critical ways, and knowing that that has to be reflected through the support of Black and Brown people and their families, as well as the leaders and organizations in the field. Next slide, please. So in approaching funding research, we really look at research justice as this framework. The self-determination, starting with self-determination, understanding that data and research are currencies that build economic, cultural, and political power. It allows people to increase knowledge in community, shift narratives, and improve outcomes. And that funding data and research with the intention of building power and self-determination in community. The next is racism as a factor. Of course, representation matters. As we've all discussed, the outcomes, the differences in outcomes when people have culturally congruent and racially concordant care. We also have to talk about the racism experienced by people in and out of the exam room, the way that that has an impact and how that has to inform our care quality, our funding, our research priorities. And then capacity is key. The resources for capacity and infrastructure building are necessary for long-term change and impact. Building up the organizations, the people accessing care, we have to build that infrastructure in order to see the change. And so to that end, research justice is birth justice. What is the care? It allows us to get to what is the care and experience that people want, who is providing that care and experience, and who has access and power in the receipt and provision of that care and experience. Next slide, please. And so in practice, this is sort of the expansive model that reflects some of the gaps and opportunities, and of course the interconnectedness of issues along this continuum of research. Our focus and the frame with which we operate is really that research is a continuum, that there's opportunity in every space to view it, treat it, and respect it as research. Currently, this work at Tara Health spans local pilots to national academic research. And we've got some partners here listed on the side, but I'll start with some of these key areas that we see really connecting and being important places of investment. Well, starting with capacity building, this is really centered around building the operating and coalition capacity of community-based organizations to inform, lead, and engage in community-based participatory research. Training. This is revising training and education in clinician settings. What does it look like to have anti-racist, justice-informed, culturally competent curriculums and care models? And how do you teach them? What's effective? Workforce and really leadership development. There's opportunity for funding to create pipelines, pathways, and places for BIPOC perinatal care providers and a place to start understanding what investment is needed to create this critical mass. Someone mentioned earlier HBCUs as this really central opportunity and place for this work. Culture and narrative shift is next. This is where we're elevating team models and the power of midwifery and doula care, naming and dismantling racism and the importance of naming the importance of cultural concordance and humility as drivers of better outcomes, and using this to drive policy. Quality improvement. Monique talked about this as well. This is another place of investment for us where we want to measure and dismantle the systemic and institutional racism in care by building research that centers the experiences of Black people. Community birth infrastructure. Where people birth and what resources exist to support the pregnancy through parenting journey is important. Where people live, work, play, eat, pray are critical inputs to the experience of birth and parenting. And also tell us a lot about the economic power within communities that informs the way that resources are allocated. On the side here, we've got some of our partners listed and a few bolded that I want to talk about that sort of span across, again, local pilots to larger academic research, starting with the Sacred Birth Study, which I know Dr. Karen Scott spoke earlier this week. This is a study to develop a prem-OB scale, examining obstetric racism as defined for, by, and with Black mothers during hospitalization for labor, birth, and postpartum in 6 care domains: safety, autonomy, communication, racism, empathy, and dignity. I echo Monique in that this measurement work is very critical to how we move forward and also start to tie quality improvement to reimbursement and other areas where investment and research needs to occur. Next is the priority study. Again, a co-funder with the Robert Wood Johnson Foundation and other foundations, and really intentionally focusing on funding the Reproductive Health Equity and Birth Justice Corps, led by a group of Black and other people of color scholars, with the real sole intent to get at how we do research and making sure that it's inclusive. This group built a community advisory council that continues to inform and hold the study accountable to how it understands the experiences of Black, Indigenous, and people of color communities, especially during COVID-19. Then there are others, for example, the Shades of Blue project, where Kay Matthews is doing incredible work to not only build a maternal mental health curriculum focused on Black mothers, starting to really get at and understand what their needs are. How do people talk about maternal mental health? What does that look like in communities where these conversations actually have been quite challenging? Elevating people like Kay, supporting their work, puts them on the stage and in front of the world in a way that where they're not normally invited. So building capacity and support there for her to do her work, trusting Shades of Blue and knowing that they are the stewards chosen by the community to lead in this way. Then we have Beloved Black Birth, Black Centering, that honors and celebrates Black birth, Black families, and Black community, allowing people to have access to a Black team of healthcare providers, family support advocates, doulas, breastfeeding specialists, doctors, nutritionists, really building this understanding of what it looks like to offer that optimal birth experience that people are seeking. And then another example is Earth, led by Kimberly Seals Allers. And this is an app that allows people to connect with each other, birthing people to connect with each other, share their experiences in healthcare settings, and empower them to make choices where they birth and who their clinicians are, and understand, what they're looking at as they enter a hospital or clinical setting. So we're really excited to be partnering with all of the organizations on this list. And this work also spans across looking at universal basic income as an important intervention, really touching again on this place of economic justice, building the midwifery pipelines, not only for people who are currently in school for midwifery, but really looking at the very beginning of the pipeline, where doulas and lactation consultants and others enter into the fray. Our partners in this work is really critical. And we have to examine not only the systems within institutions, but also we have to examine the systems within institutions that allows this work to thrive. And for funders, foundations, even educational institutions, they have to really change the way that they operate in order for this work to move forward. So I am just really excited to be able to share this with you and share our partners, the work that we're doing, how we're moving this forward, and these priorities that are really driven and led by some of the folks who are currently on this call, but other people who are out in the community that have been really informing and guiding us in the way that we operate. So thank you again for this time.